Hi, welcome to the Worthy Physician Podcast. I am your host, Dr. Sapna Shah-Hawk, a board-certified internal medicine physician. Keep life simple. You are human. You are worthy. Remember what matters to you. Our goal is to help physicians remember this and to make it a reality through addressing various components of physician burnout via podcast. This is meant to be used as a tool to help guide physicians. It does not take place of professional medical help. Opinions reflected in this are my own. So we'll just have you introduce yourself first. So what do you prefer to go by?
Bob.
Bob.
Yes.
So you go by Bob, but your full name is Robert Bean.
Robert Bean. Yep. I'm a clinical psychologist, and with the emphasis in what I call psychophysiology, or what's called psychophysiology. I'm board certified in biofeedback and do things like work with patients on that interface between psychology and physiology. And also neuromodulation kinds of things, so cranial electrotherapy stimulation, audiovisual entrainment, and those kinds of things. So a little bit different than most clinical psychologists probably, but certainly glad to be here. Thanks for having me.
Thank you. And how did you get into that? Number one, where did you do your training?
So I went to... for my doctorate, I went to the University of Wyoming, just kind of a general training in clinical psychology. I think it's just really been over the years of that's where my interest was, right? That's where I kind of ended up navigating myself to, is more and more training in the psychophysiology kind of aspect of our work. And so that's where the training in biofeedback and those kinds of things came into play, and just really also it came out of a need of various places where I've been employed, right? Where people weren't available, didn't do those kinds of things, and they were needed, and I just kind of filled the gaps as they came up, and it happened to fit what I enjoy, so it kind of worked.
Now, the first thing that you said was physio-psychology. Can you break that down? So the way I understand it is how the two interact. Is
Exactly.
Correct?
Yeah, it's how the two interact, and so it's really helping people understand that the how our physiology, in particular our nervous system, impacts us and how we can respond to that. Right, in ways that help us to better cope and better behave and to feel better. And so it's kind of that blend of those two. Yeah.
So when you work with patients, do you work with patients that are typically, chronically stressed, chronic pain?
Yeah.
Chronic conditions in general, kind of across the board.
Kind of all of the above, right? So because so much of what we run into has to do with obviously our physiology and in our nervous system, from my perspective, and we'll talk a lot about that today probably, but so it can be chronic pain, it can be PTSD, it can be stress disorders, it can be anxiety, it can be depression, it can be the psychological aspects of things like hypertension, right? Of a stomach upset, GERD, those kinds of things. How do we help the patient utilize an understanding of their nervous system, and then what can they do to help mitigate those symptoms? So it works really well in concert with the physicians and their approach to things. So it's a real nice, I think, collaboration. Yeah.
So, for example, you mentioned things like hypertension or even GERD, and those are very, very common.
Mm-hmm.
This podcast is about physician burnout.
Right.
And what I love about, we've worked together on patients and we've had, I think, remarkable outcomes by addressing not only the hypertension, right, but the anxiety, depression, insomnia, PTSD, chronic pain, and even the oh shit, I'm getting old, right? I mean,
which I can relate to.
Yeah, likewise, not as wide as you, but still, right?
Right.
There's the aspect of chronic disease, and it's, we ourselves are patients, and we can kind of relate.
Yeah.
Man, I'm getting old, or man, oh no, one hypertension medication, and you kind of foresee, gosh, how many more?
Yeah, and that's kind of another part of it too, right? With all of us, and certainly our patients, when there's a new diagnosis, I've certainly experienced this. You may have experienced this, but people that are, get a new diagnosis, especially a chronic condition, there's the whole psychological aspect of that as well, right? The what's this mean for me? What's this mean for my life? How do I manage this new road, this new pathway that I have, right? And so many patients just kind of shut down, right? And then the frustration comes from, well, this person's not, if it's, maybe it's diabetes, okay, they're not compliant with their diet, their exercise, their insulin, their metformin, whatever it is, okay, let's talk about why that is, right? And this overwhelm that can happen to anybody when they're faced with these new challenges, right? Yeah. So there's that part of it as well.
And so why would I bring you on a podcast that is geared toward physician burnout or moral injury? A lot of that is because I think we as physicians, through our training, right, we're high achievers, and I think it's, almost anybody that goes into higher education, and more of the culture, right? It's more of the gotta do everything right, gotta do everything, and we do. We want what's best for our patients, but we kind of put ourselves on the back burner. We work within a system that is not really centered around patient-physician relationship, but about everything else, almost everything else but.
Right.
And so that puts a lot of burden, right? At least as a physician, that I'm always trying to do what's right for my patients. It creates stress when you have a lot of hurdles. There's so much red tape, and that's anywhere. But looking at if the physician is the patient without going into a doctor's office, we know that the chronic stress over years, the lack of sleep, the inattention to diet or self-care, maybe not as resonating with every individual, but I think at some level a lot. And of course it depends on the specialty.
Yeah.
What does that do to us? I mean, over time, what does that stress, the increased cortisol, lack of sleep, what does that do to you mentally?
Well, actually, let's back way up, okay? So for your listeners that may not be clinicians, your listeners that may not be physicians, let's back way up if we can, right?
Absolutely.
Let's talk about what stress is to start with, the very basics. So as we look at the stress response, okay, and really what we're talking about is a part of our nervous system called the autonomic nervous system, as you well know. So we've got our central nervous system, our brain, our spinal cord, we've got our peripheral nervous system, and we've got this kind of subset of that, which is an autonomic nervous system. And think about autonomic, the word basically means automatic, right? These are nerves that help regulate our internal organs and glands automatically. So it's a very primitive part of our nervous system. So this autonomic nervous system then has two branches, right? Parasympathetic and sympathetic. And so I find it really helpful to teach our patients about this nervous system and what happens and why it happens and why it does this. Because as they understand this, now they start to understand the stress response. They have to start to understand their symptoms, their physical and emotional symptoms. So as we start looking at this autonomic nervous system and this dance between sympathetic and parasympathetic branches of this autonomic nervous system, let's think about why they do what they do, right? So the sympathetic branch, that's our fight or flight branch, right? So I always like to kind of say, let's think about why it does what it does, and it does it automatically. So if I'm walking down a path, a dirt road, and 20 yards out in front of me walks a mountain lion, I'm probably going to have a stress response, right? I'm going to have a fight or flight response. Well, what happens physiologically when that happens? Automatically, a lot of things happen. Why do they happen? So my pupils dilate. Why does that happen, right? So I'm going to get more light into my eyeballs. I'm going to have better peripheral vision, right? That's going to help me. Because think about, well, this is a survival mode.
Absolutely.
Survival mode for the next 3 to 5 minutes, right? So now I've got my pupils dilating. My breathing's going to get short and fast, right? Short, fast, and shallow, right? Why? Because I'm basically getting a lot of oxygen in a very short time for this 3 to 5 minutes. My heart rate's going to go up. Why is that going to happen? Because that oxygen has to be delivered, right? So my heart rate goes up to deliver that oxygen from that fast breathing. Okay. My blood vessels in my extremities, my fingers and toes are going to constrict. Why is that going to happen? Well, because I don't need blood in my pinky right now to survive this mountain lion, right? Where do I need it? I need it in my core. I need it in my major muscles, right? So our bodies are really efficient. They're here for survival. So now I'm pumping more fluid because my heart rate's up through less pipe. So what's going to happen to my blood pressure? It's going to go up, right? My liver is going to start dumping glucose into my bloodstream. Okay, why? I need sugar. It's the currency of energy in our cells, right? So that's why I always like to explain to diabetics that, you know, sometimes they get sent to me and they're like, I don't know why I'm here to see you, but it's like, well, I've been taking. Let's talk about it. What they say? Well, I've been taking my meds like I always have. I'm eating like I always have. I'm exercising like I always have, but my blood sugars are up. What's going on? Well, let's talk about what happened in the last 45 days. Well, my dog died and my truck broke down and we got this whole country western song, right? And there's all this stress.
I can relate.
Yeah, there's all this stress, right? So their liver's been dumping more glucose. Okay,
Right.
so their blood sugars are up.
Right.
So let's talk about the stress. Muscle tension goes up. Why does that happen? Because A, reaction time is going to be faster from a more tense muscle, right? And B, I'm braced if I get hit in this fight or flight, right? I start sweating, right? Cool my system down. My palms get a little damp. Why does that happen? That's for grip, right? They don't get real wet, they get a little bit wet. Anybody, you know, if you've ever licked your finger to turn a page, you know that a little bit of moisture helps with grip.
Right.
So we've got better grip. That helps us hold on to that weapon or climb that tree or grab that enemy, whatever it is, and I've got better grip, right? So all these things happen, and they happen quickly, right? They happen automatically, and they happen quickly. And they happen quickly because there's a sympathetic ganglionic chain. So all these nerves in our sympathetic branch are coming over our spinal column. And they're connected with the sympathetic ganglionic chain, which is, I'm old enough to remember party lines on telephones, right? Out in the country. So if one phone rang, they all rang, right? So that's a party line in our body for these sympathetic nerves, right? So they can go off really quickly. And the point of that is it's great for survival. Okay, so if I'm walking down a path and I step on a snake, boom, all that stuff happens really quickly, right? Muscle tension, breathing, blood pressure, sweating, pupils dilating, glucose dump, right? It all, boom, just like that. It's available to me to survive, just like that. Sympathetic ganglionic chain. So, or a more likely scenario is you're driving in a street in your city and somebody almost wrecks into you and you're in the median and you're sitting there and you're breathing fast and the muscles are tension, you're sweating, and all that happens just like that, right? So it's great for survival. There's nothing wrong with that.
But it's supposed to be intermittent.
Exactly. It's supposed to be intermittent. It's supposed to be temporary. It's supposed to be for survival. So the other side of this autonomic nervous system is the parasympathetic branch, okay? And it's really just the opposite, okay? So on the sympathetic branch, where all these things were fight or flight, we like to call the parasympathetic rest and digest, and it's really just the opposite. So now my pupils constrict, right? My muscles get loose, my breathing gets deep and slow. Before, what I didn't mention, in our fight or flight, the digestion shuts down. Okay, right. So we start to have less digestion. So now in the parasympathetic, my digestion kicks back in. Like I said, breathing deep and slow, heart rate starts to slow down. Just the opposite. So I like to tell people it's like a teeter-totter. As one goes up, the other goes down. Right? So there's this balancing act. The problem is, so many of us live in a world where, because any change or challenge, good or bad, big or small, kicks in some of that fight or flight, some of that stress response. So any change, good or bad, big or small, any challenge, good or bad, big or small, kicks in some of that. Now, it's not as strong as you stepping on the snake or seeing the mountain lion, but right. Some of it's kicking in, right? So, do you have much change or challenge in your life? Do any of us, right? Right. I always like to say I get more on my phone by 8 in the morning than my great-great-great-grandfather sitting on his farm up in Iowa probably got in 8 weeks. But my nervous system is still the same as his. Right. So as human beings, we've created this world that has constant change and challenge, but we've got a nervous system that is now constantly triggered. Right? So add that to a physician's lifestyle. Add that demand to it. Right. Right? Now what happens to our autonomic nervous system?
So it's not just the phone, but plus or minus a pager, depending on if you have the phone for admission or the code pager. So it's potentially 2 phones, 2 pagers.
Exactly.
I mean, I'm recalling from, being on call, residency.
Yeah. So now those demands are even higher. So that fight or flight is kicking in all the time. Right. And if we have this dysregulation of that autonomic nervous system, where that fight or flight is constantly activated, eventually our body says, ouch, right? And it starts to shut down, it starts to hurt, and it starts to have distress. I always tell people stress is not a bad thing. Stress is great. The stress response prepares us to perform well. It saves us. It helps us. Stress is not what's bad. Distress is bad. That's when the stress is overloaded, right? So there's a cumulative effect to this. You know this as a physician. Physiologically, there's a cumulative effect to this, so that if my digestion's shut down for a day or two, not so bad. If my digestion's dysregulated for a month, bad things start to happen, right?
And how would those manifest? I mean, we as clinicians know how to diagnose it in patients, right? But we're constantly on the go. I'm not. But
because you've learned, right? You've adapted.
Right.
Yeah, you've adapted.
It's like, I want to be around you to be 75, 85. I enjoy life. Right?
Yeah.
For me, it's more than just work. It's a work-life balance. This is what I needed to do for my family. Yeah. And you've met them.
Yes.
They're quite delightful.
They are. Wonderful. They're wonderful. Yes.
But for those that maybe have not had that insight or have chosen to not cut back, how does that manifest? How does that manifest?
It kind of depends on your diathesis, right? Your vulnerabilities,
right?
The genetics that you bring on board, as well as your history, right? So everybody's a little different, because with distress, there are physical as well as emotional symptoms of distress, right? So, and that stress is cumulative, and the distress is cumulative. What I like to, kind of visualize it as this bucket that we have, where we can tolerate a certain amount of stress. Mm-hmm. And every change or challenge that we run into is a little bit, it's like putting a little bit of water in your bucket. And that's fine up until that bucket gets full. And when it starts to overflow is when we start to have symptoms of distress, both physical and emotional. Right? So, and there's times when we are stressed at a point where if you have a loved one die, there's not a bucket big enough for that. We're going to be distressed. It's like a fire hose into our bucket. There's no bucket big enough. But for most day-to-day life, most of us have been blessed with a bucket large enough to handle the load, right? People have different sizes of buckets. Some people have a smaller bucket. Some people have a bigger bucket, right? But most of us are able to tolerate a certain level of stress. But at some point, if we're not managing this load, then it starts to overflow, and that's when we have those symptoms of distress, right? So that's when we have to start looking at when do I not feel well, and being more attuned to that, both physically and emotionally, right? So that is the first part. That is the kind of the old way of thinking about the autonomic nervous system, sympathetic, parasympathetic, and this kind of teeter-totter balance. And you know, I like to think about the sympathetic as like the gas, the accelerator on your car, the parasympathetic like the brakes. One is not bad or better than the other. We need both, right? But you have to have a balance of both. And and the problem is, too many of us run around with that accelerator punched, and we lose our ability to brake. And so then that's when the things start to break down, or we start crashing, running into things. So there's this balance that has to occur. Now, physicians are kind of like race car drivers. They're really good at running with the accelerator pushed down to the floor, right?
That's a good analogy. It's
right?
Right, yeah.
So and so there's a habituation to that. There's a normalcy to that. This feels normal to go 180 miles through the streets of Monaco, like an F1 driver, right? This feels okay. But the problem is you still have a car like everybody else.
Right.
And eventually that thing starts to break down, okay? And we start to have those troubles, okay? So it's a matter of recognizing that and being aware of that. So there's that part of it, right? So then we start thinking about Stephen Porges' polyvagal theory. I don't know if you're familiar with that, but it's more of a theory than it is actual physiology, but it makes sense to me. So let's talk about that a little bit.
I'm actually not familiar with
Okay, so the idea is that parasympathetic branch. Okay, so what I didn't say is on the parasympathetic side, as you know, the vagus nerve is the primary nerve of that parasympathetic branch, right? That's our 10th cranial nerve. There are a few other nerves that are involved in our parasympathetic, but that's the main one. That 10th cranial nerve is our vagus nerve. And so vagus is Latin for wandering. They named it the wandering nerve because it wanders all throughout our body and it hits all these internal organs and glands, right?
Right.
So we've got this wandering nerve, and that's the primary nerve that kicks in this relaxation response, this rest and digest response. So we've got this balance then. And so that's the thing with the autonomic nervous system. We've got two sets of nerves. It's the same system, autonomic nervous system, same organs and glands, different nerves, right? So with the sympathetic branch, we've got all those nerves coming out of our spine, that sympathetic ganglionic chain that we talked about, and then on the parasympathetic side, we've got this vagus nerve, okay? So what Stephen Porges proposed was that there's really two pathways to the vagal network, okay? So one being what he called the ventral, the ventral vagus, and the other one he called the dorsal vagus. So the idea is, and this makes sense to me, and this is where I think it really fits into physician burnout. The idea is that dysregulation or the out of balance we talked about with the parasympathetic versus the sympathetic, and that sympathetic always being activated, and we get into distress, our water bucket's starting to overflow. So we're in fight or flight, right? So fight looks like irritability, anger, frustration, right? That just on edge.
Sure.
Flight starts to look like anxiety, right? Fear, those kinds of things. So what Stephen Porges said is that if we stay there long enough, we eventually get into what we used to call the freeze response, okay, and which he calls now ventral vagal. And this is the shutdown mode. We've blasted through fight or flight.
Right.
And now our system starts to get into shutdown.
What shutdown?
Okay, so we start to look at things like disassociation, right? So the things that sound like, if you do the burnout scales, right? So what we got? Depersonalization, right? Shutdown, numbness,
right?
Those kinds of things. So we've got depression, helplessness, shutdown, hopelessness, feeling trapped.
Sure.
Just this. So there's this shutdown mode that starts to happen. Okay, in that dorsal vagal. Okay, so we've blasted through fight or flight, and now it's this real protective mode of I'm just shutting down.
And we've developed a lifestyle, right? Technology has every aspect of our life has just accelerated as far as development, but our nervous system has not.
Yeah.
So 100 years ago, this would say, okay, remove yourself from this situation. But now, why are people not in tune to that? Or why are physicians not in tune to that? Let me ask you that.
I don't think people in general are in tune to it, right?
Okay.
Because we've developed an even faster world, right? Even faster world. And I don't think, and that's the struggle, and that's the reason, that's the problem,
Sure.
is we've kind of lost this understanding and awareness of our physiology in our body. We kind of just blow through it. So we end up then ignoring the stages of distress from fight or flight.
Sure.
And then we are so overwhelmed that we end up with burnout. We end up with this, what Porges called, this this dorsal vagal shutdown, right? And it's a protective mode,
Right.
where it's just like, I am totally shutting down here. Okay, to me that sounds a lot like physician burnout,
Yes,
right?
Absolutely.
Yeah, so now we've got, that's what we're talking about from a psychophysiological standpoint, right? When we're talking about physician burnout, we're talking about dorsal vagal shutdown, right? Total shutdown. We've blown through fight or flight because, as I said, physicians being high achievers, that's just kind of normal. We just go through it. We just keep going. We just, that's what you're supposed to feel, and then we blow through it, and we don't understand why all of a sudden I'm shutting down, and I don't feel like myself, and I'm numb, and have no energy, and I don't want to get up in the morning, and I just want to sit in a room by myself for 3 weeks. Sounds really good. I'm starting to fantasize about being a lighthouse operator, those kinds of things, with my cat, and a book, those kinds of things start to sound really good because we're starting to shut down into that dorsal vagal mode, which is a survival mode, right? So that's the part that makes sense to me from Stephen Porges' theory, okay, is the separation of the parasympathetic into these two pathways.
Right.
So the other pathway is the ventral vagal pathway, and this is the healthy pathway. This is so we, depending on one's beliefs, we either evolved or were created or both, as we as human beings are social creatures.
Right, absolutely.
That's how we survived.
Right.
We don't have big claws. We don't have big muscles. We're not really fast. We're kind of slow creatures. We can't climb well. We don't have fangs. We can't. We're not very good physically as a species. Right. So that's not how we survived. So how did we survive? Over the eons, we survived by communing, by coming together. And so our nervous systems developed that way.
Mm-hmm.
So we feel safe, we feel good, we feel comfortable, parasympathetic, when we are with other people, right? That is our network. That's where we feel good, and that's how we replenish, is with other people. And so we have this need for social engagement. And without the social engagement, then we end up being stressed and distressed. And we end up with too much sympathetic activation, or we get clear over into that dorsal vagal shutdown. We have to have this to survive. Okay? Make sense so far?
Absolutely. Yeah. Now, I'm going to, you might think, well, I see, 20 patients a day either in clinic or in the hospital, and I see my colleagues, I see plenty of people in the hospital or at work.
Yeah.
So what's the difference? Because we're social there. But what's the difference? Can you kind of tease that out?
Yeah, well, because those are demands, right?
Okay.
So there is the social support. There is the social assistance, right? So we and it is the interactions that happen within that. Right? So human beings have 42 facial muscles. Okay? So a lot of our communication is nonverbal.
Correct.
Right? We don't have to, we have so much interaction. So what Porges calls neuroception, where it's even below our conscious awareness, our nervous systems are constantly assessing threat versus non-threat. Okay? And that includes interactions with others, because not every human being is friendly and not every human being is safe, right?
Right.
So even in our own species, we have that issue. Okay? So when you're at work, that's not the same as sitting around the campfire with friends. Right? There's demands, there's pressures, there's expectations. Change or challenge. Remember, even good or bad, change or challenge creates a stress response. So we're still kicking in that sympathetic nervous system at some level all day long, even though it is a social connection. Right? So we've got to have a positive social engagement for us to be healthy, for that to happen. So that's the ventral vagal part.
Okay.
Right? So there is this need for that. And when we have that, then we re-engage in life. We feel good. We feel comfortable.
Right.
We have less of the physiological distress, less of the emotional distress.
Right.
When we're engaged like that.
So that's going back to the communal, this is my tribe, this is my family, right? Exactly, right?
So that's really important. And so if we look at, let's just use COVID as an example, okay?
Sure.
We just lived through this incredibly stressful environment, this incredibly stressful time in our species. So why was it so difficult? Part of it was we've got this threat that's invisible, doesn't have a smell, can't see it, can't hear it.
Right.
But it's there. It's real. So I don't even have a tangible thing that I can use my senses to notice.
Absolutely.
So my senses are constantly scanning the environment and there's nothing there to see, but then I'm really scared because I can't even identify where the heck it is.
Right. Then the incubation time was unknown. The
Yeah,
next 2 weeks,
yeah.
Exactly. But still.
And so then what happens? What's the recommendation? Social isolation.
Right.
Human beings, that's the exact opposite of what human beings need to feel better, for that ventral vagal, because that's how we get through stress, is to commune and help each other and be together and hug and, keep each other safe and all that stuff.
I think that's pretty much how we made it through the work week, because we had a pretty therapeutic Friday morning.
Yeah, exactly.
I mean, seriously. Right?
Exactly. No, that's exactly right. And that's why in work environments, the small tribe, right? If you build that small tribe and you have a work environment where you have others that you trust and feel safe with and can be vulnerable with,
sure, then
that helps you get through those stressors of the week, because you just met with your tribe.
Exactly.
If you don't have that, it's horrible, right? And it makes it almost intolerable. So COVID, we're told, don't commune, stay at home, right? So then what happens? Think about Maslow's hierarchy. Now, Abraham Maslow is a psychologist in, the mid 1940s to 70. I think he died in 1970. So Maslow's hierarchy, I don't know when he developed it, in 1950. It makes total sense.
Sure.
Even though it's that old, right? So And basically what he said is we have a hierarchy of needs that build upon each other. And unless you meet the lower level need, you're not going to get to the next level of need.
Right.
So the very first level of need is your physical needs. Food, water, that kind of stuff. So think about COVID. What was the first thing that we saw? It was very predictable. People ran out.
Right.
People ran out and started hoarding.
Right.
Basic needs, right?
Absolutely.
I remember going to Walmart and looking at the aisle for like soap and disinfectants and bandages, and they were gone. It was wiped out.
Yeah.
Totally gone, right? Because people are going to first meet that basic need of physical needs.
Right.
Food, water, physical needs,
Absolutely.
health. So then after that comes safety, right? So we got to find ways to have safety and security. That was really hard with COVID because, again, the threat was not tangible, right? And the answer took us away from commune, being with other people. After that need, if we get safe, if we're in a safe environment, the next need is love and belonging, connection with others,
Right.
according to Maslow, right? And so it totally makes sense with Porges' new polyvagal theory, right?
Yes.
Even though it's 70, 80 years old. Because then we've got to have that need met before we can even get to achievement, self-esteem, which is the professional part of it, right? If I'm not getting that need met, I'm not worth a dang as a professional. I don't even care about it. I start to lose my interest in it because I'm not getting these needs met. So it becomes less important to me. I start to check out. I start to get numb about it.
Right.
Those kinds of things. I don't have an identity with it. I start to disidentify with it, right? I start to have that, that depersonalization we talk about, where I'm just kind of numb. I'm not connected to it. It's not me, and all that.
That's exactly what we see with physician burnout.
That's
what
what
I'm.
Yeah.
But working, not engaging with your friends, family.
Exactly. Yeah, exactly. Right. That's why. That's when you start thinking about physician burnout. This autonomic nervous system stuff is what makes sense to me. Right.
Absolutely.
Totally makes sense. That's physician burnout, is this whole thing about being out of balance with our autonomic nervous system, getting overwhelmed, blasting right through fight or flight, because physicians kind of live there anyway. That's just, they habituate to it. They're the race car drivers of the world, right? And so blast right through it, and next thing you know, there's that numbness, that depersonalization, that shutdown, right? That withdrawal, and feeling ineffective and sad and down and all those kinds of things, right? So
what you believe or where you've been, politics, your religion, or the color of your skin. We've all been guilty and made our own mistakes, said and done the things to perpetuate the hate. Hey, I think it's time to turn around. Hey, and begin again. Hey, I think that I can look in the mirror and start again. The second time around, the second time.